So last, but by no means least, Germaeline Vanderlee, did I get it right? Thank you, is going to talk about sexual and reproductive health needs assessment proposal. So we're going out with a bang, as it were, today.
I think I totally missed that comment. All right, I'm going to try to make this as quick and painless as I possibly can so we can all get out of here. All right. Oops, sorry, wrong. So most of you know who I am. My name is Germaeline Vanderlee, and I did my practicum at my usual place of employment, which is with the Research and Innovation Department within Population, Public, and Aboriginal Health Division of Alberta Health Services. So my culminating project was essentially to develop and design the needs assessment study, identifying the access needs of urban Calgary communities for sexual and reproductive health services. So my deliverable for AHS was essentially the study proposal, along with the primary data collection tool, which is the survey instrument. So today I'm going to be talking to you a little bit about the key elements of the proposal, as well as talk a little bit about its limitations and public health implications. All right, so a little bit of background. In April and May of 2013, all SRH services across Alberta underwent provincial review due to regulatory issues associated with selling low-cost birth control supplies. So according to the Pharmacy and Drug Act of Alberta, a license is actually required to be obtained from the College of Pharmacists in order for AHS SRH clinics to sell low-cost birth control supplies to their patients. As a result, AHS had to temporarily suspend this practice during the review. It's important to note that around the same time, the Society of Obstetricians and Gynecologists of Canada's Contraceptive Compassionate Assistance Program, which is the main source of free birth control supplies across Canada, was also discontinued. So AHS SRH clinics were not only unable to sell low-cost birth control supplies to their patients, but they were also very limited in free birth control supplies during the review. So the clinics have since resumed practice, but it was essentially this temporary change that led urban SRH clinics to pursue a community needs assessment. So going right into the needs assessment proposal itself, it has two main objectives. The first is to define the populations that SRH clinics across urban Calgary is serving. The second is to identify the access barriers that exist within urban Calgary communities for SRH services. There will be three questions that will be answered. The first is, what are the characteristics and deprivation level of the birth control seeking population specifically? The second is, what are the characteristics and deprivation level of the general SRH clinic population? And the third is, what are the challenges and barriers that exist within urban Calgary communities for SRH services? So the needs assessment was essentially designed and developed using an integrated knowledge translation model, where a knowledge user, so in my case, the SRH clinicians and decision makers, are essentially engaged and integrated throughout the study process. And they are integrated because they bring in unique perspectives into the study process, and they're also very well positioned in moving the results into practice. So the IKT model essentially facilitates the transfer of findings to ensure that actions are taken in order to address the gaps that are found in the study, if there are any. So the needs assessment has two main components and data sources. The first is the retrospective chart review, which essentially involves working with previously collected birth control data during April and May of 2013. So this time period is essentially chosen because it's the only time period when the clinics actually collected additional information about the population who accessed their birth control supplies during the review, which will hopefully enable us to do a little bit more of an in-depth analysis of the birth control seeking population's demographic characteristics, as well as assess their level of deprivation. The second component is the cross-sectional survey, which involves gathering data using the study-designed, self-administered, semi-structured questionnaire, which comprises of 26 open-ended and closed-ended questions. The questionnaire itself asks a variety of questions around demographics, such as sexual orientation, employment, education, and social status. And it also asks questions around access barriers specific to the clinics themselves, as well as the communities in general. So I do want to note that the questionnaire was written in English plain language at a grade 9 readability level. It was also developed using the scoping review that I did in PHSP 506, and was also pre-tested with a few individuals to increase its face validity. So in terms of sampling and recruitment, there are 4 urban SRH clinics across Calgary, and all of them are going to be participating in this study. Although I do want to note that for the retrospective chart review, we only have data from 3 of the 4 urban sites. That's because the 4th one only opened a couple months prior to the temporary change in practice, and therefore did not dispense any birth control products. For both components of the study, samples will be taken using convenience sampling technique. So we're only going to be gathering data from people who actually make it to the clinics themselves. In terms of data collection, for the retrospective chart review, we are only retrieving non-identifying information for analysis. For the cross-sectional survey, the survey itself is actually delivered in paper format by clinic staff. Incentives for patients to complete them include a little package with free condoms and candies, as well as a ballot form that they can complete for a chance to win one of 10 $20 gift cards to Subway. The clinic staff are encouraged to offer the surveys to patients through the assessment of the overall clinic response rate at the end of the data collection period. So whichever clinic has the highest response rate will essentially win a big basket full of goodies. So for data analysis, pretty straightforward for both components of the study. Data will be analyzed using descriptive statistics. For the cross-sectional survey, because we have open-ended answers, that data will then be analyzed using content analysis, and themes will be generated from the answers. As well, because we want to assess the level of deprivation that the clinic population is facing, we are going to be using an analytical tool which is developed by the Quebec Public Health Institute called the INSPQ Deprivation Index. So this is a map of Calgary, which essentially illustrates the material deprivation of the communities within Calgary. So what we're going to do is we're going to take the postal codes that we've collected from both components of the study, and we're going to link that with the associated dissemination area in the index, and then a deprivation category level from 1 to 5 is then assigned to the postal code. So a deprivation level of 1 essentially means least deprived or higher socioeconomic status, and a deprivation level of 5 is then meaning most deprived or higher socioeconomic status. I do want to note, though, that the deprivation level associated for each postal code is based on an area in which a person resides. It does not take into account individual circumstances or situations. In terms of consent, there is no consent required for the retrospective chart review, but for the cross-sectional survey, consent is essentially implied upon completion of the questionnaire. Other ethical considerations. So the needs assessment, we didn't have to go through formal research ethics review. Instead, we went through a RECI second opinion review. So a RECI essentially stands for a Project Ethics Community Consensus Initiative, which is a group of organizations around Alberta that work together to integrate ethics into knowledge-generating projects. And so the second opinion review is essentially a peer review process where they take a look at our proposed protocols, our methods, our survey, and other materials to be used in the study. And they make recommended changes to ethically strengthen them or to ensure that we meet ethical standards. So right into the limitations, there are a number of them. So the first is the convenience sampling method. So with this one, we are potentially missing data from people who may be experiencing greater access barriers and who can't make it to the clinics themselves for one reason or another. The second, the instrument, well, it's only available in the English language. It's not going to be interpreted. It's not going to be translated. Because it's written at a grade 9 readability level, there is a potential that we might be surveying people who have trouble reading or speaking English, or who may have lower than grade 9 readability level, and therefore might find it challenging to complete the survey. They might answer questions that they don't fully understand, or may opt not to answer the questionnaire at all for these reasons. So for these two particular limitations, the study may have a higher likelihood of underestimating the level of access barriers that exist within urban Calgary communities. Another limitation is that we are missing that one data from that one urban site for the retrospective chart review. We do know that this site serves a really highly underprivileged population, and so we might be missing some data from that vulnerable group. But I do want to note that for the 3 other sites we have data for, one of them actually serves the same population, and so it's actually only a few minutes away from this particular missing urban site, and so there is a potential that we might have some data from that vulnerable group as well. Another limitation is the deprivation index. It has 2 key limitations. The first, I've already noted earlier, it does not measure individual socioeconomic status, so the deprivation level is based on an area, a neighborhood. in which a person resides. The second is that it does not take into consideration a couple of social factors, particularly immigration and Aboriginal status, which we know are associated with certain health outcomes. And so the deprivation index is really just a proxy measure for socioeconomic status. So what are some of the knowledge translation strategies? So once we have, thank you, all the data and we've analyzed everything, there's a number of things we're thinking of doing. The first is to present it to AHS executives as well as future AHS family care centers. We're also going to be sharing the information with the AHS Provincial Contraceptive Dispensing Working Group, who is accountable to the Senior Medical Officer of Health to help with his upcoming negotiations around contraception dispensing. And we're also going to be sharing it with the patients visiting the urban clinics. Finally, what are the public health implications? Well, there's a number of them. The first, it allows the urban SRH clinics across urban Calgary to better understand the populations they are serving. It helps them identify gaps in access needs for their services, which will hopefully inform their plans for full program evaluation, such as quality improvements, as well as assess the social return of investment of the services that they provide. It will also help them identify changes required to their clinic infrastructure as well as their service provisions, and also identify ways to modify their outreach services to better target those who are experiencing greater access barriers and to also better meet the needs of the community. And finally, the information we gather will hopefully inform their discussions with external stakeholders such as primary care networks, as well as other youth clinics and services across Alberta. And that is essentially it. So I'd like to thank my practicum supervisors, Dr. Cindy Johnson and Deborah McNeil, as well as the SRH partners I work with to develop the proposal and the survey instrument. And of course, I can't forget faculty from University of Victoria, Kathy, Lynn, who's my second reader, and Victoria Barr, and also Betty, and my faculty, or sorry, everybody else in the cohort, and also my family. Thank you. Any questions?
Happy dance. Questions? So
Is everybody glad they're gone?
Yeah! Thank you very much.
I have a question for you.
Sure.
How did you manage to put such incredible information in such a short period presentation?
I have no idea, but
Okay, that's the right answer.